Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Special Considerations, Episode 3, Pain Management. After viewing this episode, participants will review the importance of pain control. Participants will review the verbal and nonverbal indicators of pain. Participants will review non-pharmaceutical methods to control pain. And finally, participants will review pre-hospital management of pain.
Well, pain management is something that EMS providers traditionally have not done very well over the years. We've made great strides in advancing that awareness and intervention level over the last 5 to 10 years. But pediatrics is something we don't encounter a lot as far as percentages of calls that require pain management. So it's something we're still struggling with, I think, to some degree in EMS. The recognition of the child's perception of pain and the impact they have. Sometimes they under exhibit as far as the type of pain or the amount of pain, because they can't really express themselves sometimes because of their age and cognitive ability. So we have to look at kind of nonverbal presentations as well to evaluate levels of pain.
There's probably hundreds of articles that suggest that one is that we underappreciate pain and undertreat pain, and even the most recent article suggests that we are improving, but we have not yet eradicated that issue where we underappreciate, undertreat pain.
Sometimes in the pediatric population, it's really hard to sort out pain from fear. Children don't like strangers, so they cry. Kids are hurt, and so they cry. So you have to kind of develop your own little tool set on how to evaluate kids that you don't know. The problem with doing pain management in the field for some patients, for an example, a belly pain patient, a non-traumatic belly pain, sometimes giving the medication masks what the problem is. If you have a patient that's out of control, or you have a patient that has an obvious injury, and pain management is where you need to go to get that patient in the hospital safely and comfortably, you should go there. Trauma and limb and extremity injuries regularly will call in and ask for orders for morphine on kids, even small kids. And just taking the edge off. You may not be able to get the pain all the way away, but being able to take the edge off sometimes will gain you huge confidence that the child will have in you.
Pain management is underappreciated in pre-hospital care. It's hard to identify and rate pain in the pediatric patient. Pain control can mask injury, however, it is important for safe and comfortable transport.
Children who are in pain tend to be quiet. You're not going to see any smiles. You may see them not want to move. The classic, for example, nursemaid elbow. They're happy. They're happy if they're sitting on mom's lap, but they won't move that arm. Or if you see a child is reasonably consoled until the mother picks the child up, suggesting what's going on. Is there a rib fracture? Is there a clavicle fracture? So children oftentimes will be, especially the young child, will be fine until you touch the area that seems to be uncomfortable. Older, more verbal children will tend to be quiet. They'll tend to be scared. They'll tend to, breathe fast. They may be diaphoretic. The child will look sort of sheepishly towards mom and dad, like, please help me. They may, be more obvious, crying, screaming, yelling, inconsolable. They stub their toe. Certainly it's not life-threatening type of pain, but it hurts. It's, from their standpoint, it's about as significant pain as the child has experienced. On the other side of the coin, a different child who stubbed their toe may just pout and keep their eyes closed and breathe deeply, and something's going on. You're trying to talk to them, and they're not necessarily verbally expressing what's hurting, but you can tell that something's bothering them. And again, it may take time to try to converse slowly with the child, gently with the child, incorporate mom and dad to see if they can try to say what happened.
There's some things that are very obvious. A child will be in pain if you go and you see an obvious deformity of a limb. But if a child's gone over their handlebars and hit their stomach on their handlebars, they could be in a great amount of pain in their belly, and all you're seeing is a small bruise. The things you want to look for are, is there anything that's comforting this kid? Are they putting themselves in a position to protect a part of their body or guarding? Are they curling up in a ball? Are they trying to protect that area? And you want to look at their vital signs. A child who is in a lot of pain and is not crying will have a high heart rate, and their blood pressure will be high. Their body's trying to compensate. You'll see that their vital signs are a little higher than normal because that's how their body's reacting to the pain. Especially with older children or teenagers, we often ask them if 0 were no pain and 10 was the worst pain they could imagine, what would they give you? And something that might be benign to you, they'll give a 10. The thing that's important to remember is that this might be the worst pain this child's ever experienced. So it's always important to remember that pain is subjective. So something that may not bother you may be the worst thing that's ever happened to this kid. In the smaller population, the scale that we use here at the hospital is called FACES. And it's a 0 to 10 scale in increments of 2 that has different faces, from a smiling face all the way down to a crying face with a big frown. And you use the tool, not you look at the kid and try to fit the kid to the face. You show them the faces and say which of these is how you're feeling right now. The part of it that becomes difficult is sometimes you'll have a child who has a terrible injury that you can look at, and the kid wants to be the smiley face, no matter what. So they'll pick the smiley face, and you'll have to use other measures, looking at their vital signs, how they're positioning themselves to figure out how much pain the child's in.
Identifying pain can be obvious or not obvious to the responder. Pediatric patients show pain differently. They can show it through body posture, but a detailed physical exam is the best way to identify an injury and pain location. Abnormal vital signs can be a sign of pain. Older patients can use a 1 to 10 rating scale. Younger patients use a visual scale like the FACES scale.
Well, certainly when there's acute pain, presented from a musculoskeletal injury, a fracture, for instance, we certainly want to give what comfort the patient that they deserve. Traditionally this requires IV intervention, which again, pediatric patients is a group of patients we don't encounter a lot, so we don't have traditionally a lot of experience with pediatric IVs, so sometimes that's a challenge to paramedical personnel. But that's something that's encountered more often and expected to be done in times of interventions where that are appropriate for management of pain. Well, the resources are not both pharmaceutical and non-pharmaceutical. Obviously, as in any pain management issue, we try to do the non-pharmaceutical first because that's less invasive and a lot of times very well tolerated by the patient, such as ice, elevation, splinting fractures, placing patients in positions of comfort. Sometimes that can alleviate pain to a point where very little, if any, pharmaceutical intervention is needed. When it is needed, morphine is the traditional analgesic for pre-hospital care. It's easily administered, very well tolerated by many patients. It's given in doses that are the same as adults, 0.1 milligrams per kilogram. And it's generally given IV.
Non-medicated ways to alleviate pain in the pediatric population vary from child to child. Sometimes it's position of comfort. It's having the parent with them. Sometimes distraction techniques, having a book that they can look at, or them not being able to see what their injury is, may take some of the pain away. Talking to the child and trying to keep them distracted. Sometimes warmth, using pillows for positioning different limbs, and in limbs especially, splints will make a difference in that there's not as much moving around of it. You also want to make sure you very gingerly move these kids, even on their gurney, going over a bump or the bump in the road that we can't avoid hurts. So just keeping an eye out for that.
Managing pain includes splinting, ice, elevation, and distraction techniques. Pharmaceutical intervention includes IV morphine. Please review your regional protocols for specific use of pharmaceutical interventions. After viewing this episode, participants will review the importance of pain control. Participants will review the verbal and nonverbal indicators of pain. Participants will review non-pharmaceutical methods to control pain. And finally, participants will review pre-hospital management of pain.